our second speaker is Dr. Xi. Dr. Xi is the assistant professor at Xinguang Memorial Hospital in Taipei, Taiwan. And Dr. Xi will present novel findings related to subpulmonary dynamics observed during DISE. Let's welcome Dr. Xi.
Good afternoon, everyone. Thanks for the AAO for me to have this chance to have this talk. We're talking about advance in Asia OSA. Also, we continue with the topic of Dr. Xi. We talk about interventional DISE and then how do we use the interventional DISE to do the personalized precision treatment. And I'm from Xinguang Hospital and also the National Yangming Jiao Tong University Brain Science Institute. And first of all, I have to make a statement that we have to do the interventional DISE. Why? Because the upper airway is very dynamic, so we need a dynamic exam to check upper airway's dynamic. And how do we check? This is our Xinguang Hospital's interventional DISE protocol. First, we have a patient lying naturally supine and have the patient's head turned to the side. Then we forcefully close the mouth. Then forcefully close the mouth with head rotation. Then we can use the oral appliance, either non-customized or customized, because this customized oral appliance or non-customized oral appliance can have different jaw thrust, which is very objective to see the patient's dynamic of upper airway. This is our non-customized oral appliance. This is very easy to use, and we can use it repeatedly if it is infected perfectly. And then if a patient have the desire to use the oral appliance or mandibular advancement device, we can ask them to have some pay some money to use this jig to make a temporary customized oral appliance used in the interventional DISE. And this is our interventional DISE publication. Since 2017, we found that if we use the manual injection of propofol, the tongue-based obstruction is not accurate. Then in 2021, we found that if we use target control infusion, tongue-based obstruction can correlate to the pre-op and post-op outcome. So we have to use more accurate injection method to when we do the DISE. Then we found that INAP can be used in TCI DISE. Then in 2023, we found that if we can use the interventional DISE to help us to phenotype the patient. If this I will explain later. And then we found that head rotation with mouth closure is better for the anterior posterior epiglottic collapse, and the head rotation in oral appliance plus weight control is better for the lateral epiglottic collapse, because for those lateral epiglottic collapse found in DISE is related to the body weight. Then finally, we will discuss more thoroughly for the new findings is pyrethroid biopharyngeal obstruction and how is it related to our treatment options. And this is our phenotyping for the interventional DISE. If we found that when we use intraoral negative airway pressure is effective, we found that those people are thinner and older. and we can ask them to use the intraoral negative airway device. And if we found that head rotation is good for the patient's upper airway, we can ask them to do the positional therapy. Then, if the oral appliance and head rotation both fail, if the obstruction level is in the bileopharynx, we can do the bileal surgery with weight control, because those patients are usually overweight. And if there is a tongue-based obstruction present in the even when we use the oral appliance and head rotation, those anatomically defect should be correct with the tongue-based surgery. This is a more thorough version. If we found that positional surgery is good, we can use, and if we found oral appliance can be useful for patients upper airway, we can use MAD therapy. And if both failed, now we surgeons can have a role for these patients to help alleviate their symptom and obstruct OSA. So interventional DISE, TCI DISE have a lot of advantages. We talked about that the tongue-based findings can be is accurate, and we can provide treatment options, phenotyping the patients, and during the years doing the interventional TCI DISE, we found not only inhalation is important, expiration is also possible to have obstruction. And this is called expiratory biopharyngeal obstruction. And this is a figure to show that how it happens. Because when we saw the patients have oral breathing, we usually think they are nasal obstruction. However, a lot of people, even if they have, they don't have nasal obstruction, they still have to open their mouths when they sleep. Why? Because they cannot, when they cannot exhale through their nose. When they exhale, the palate flip upward and close the bileopharynx. And so the exhalation air cannot pass through the nose, and it passes through the. You have to exhale through the mouth. This is called the expiratory biopharyngeal obstruction, and we found that it's closely related to oral breathing in the sleep. Let's have a case. This is a 41-year-old male and technician at the hospital, the home sleep test. We found that he had usually we define it's not OSA. However, when we look closely their sleep test, we found he sit up every 1 hour. Why? It had very bad interrupted sleep, but without OSA. And these patients come in my office and have a lot of complaints about their sleep, about his sleep. He said he wakes every hour for drinking and urinating, and very tired in daytime, even sleep early, and snoring noted by his wife. So his upper airway definitely have problems. Even he don't have OSA, and sometimes he stop breathing and gasping, and often sit up when sleep. Because he cannot have good sleep, he usually late to work and have bad work efficiency, and boss is very angry because he usually his work performance is not good, and last but not least, he has sexual dysfunction, have to hide from his wife. This is his DISE. Sorry for the, and we can find that when he opens his mouth, he has bileopharyngeal concentric obstruction. When we close his mouth, we can hear the snoring, but this snoring is not from inhalation, it's from exhalation. He cannot exhale through his nose. So when he exhales, we can hear loud snoring through his diaphragm. This is called inspiratory biopharyngeal obstruction. So what do? Because he don't want the oral appliance, we make a surgery for him, especially for the biopharynx, we have to make it larger for him to able to exhale through his nose. Then immediately after the surgery, he feels refreshed after sleep, and less dizzy and good spirit. And usually he cannot sleep, and he has to sleep 10 more hours, but still feel very tired. And after the surgery, he only needs 6 or 7 hours of sleep. He won't wake at night and have better focus and concentration, better work efficiency, and less snoring, better vision, less palpitation, and last but not least, he has sexual ability come back, and his wife is more satisfied. So even the patient did not have always say he still have a very important problem we need to solve. And what's the problem? This is my hypothesis. Because people cannot exhale through the nose, they have to open mouth because of the EBO. So they have to use mouth to breathe. And in this time, even you ask the patient to close their mouth with the mouth taping, it's not effective because they will push it out like this. You cannot mouth tape them. So when they open their mouth when sleep, there is no support of tongue base. They have dry mouth. They will wake up because of dry mouth. Their sleep will be interrupted, and they have more airway obstruction, more desaturation, more snoring because of oral breathing. And when we solve the EBO, we enable nasal exhalation. Then we can have patient don't have to open their mouth to exhale, so they don't have to use their mouth to breathe. There will be when you at this time, you use mouth taping, that it will be effective. And because you close your mouth, you have better support of tongue base. It will be less airway obstruction, less desaturation, less snoring, and less dry mouth. So your sleep won't be interrupted. It will be continuous. It will be better sleep quality. So another example, and this is a 51-year-old female traveler. His AHI is 27. He's an OSA patient, definitely. She's an OSA patient, definitely. But she come in my office because of the loud snoring, annoying the others when they sleep with her. And he also mentioned that he has dry mouth when awake. They can feel enough sleep. So we can see that if he lying supine, the desaturation is very severe. And this is her DISE. Oral breathing. Immediately, when she opened her mouth, we found the concentric villus glands. And we forcefully close her mouth. You hear the snore, but it's not inhalation snore, it's exhalation snore. So we found the EBO when expiration. It caused her snore. When we take the cell phone more closely to her neck, we found the snoring is more permanent. So this is inspiratory snoring when mouth closure. So for these patients, you cannot ask her to do the mouth tape. Even if you find you won't have even if you found his airway is open when she closes the mouth, but she cannot close the mouth because he cannot exhale through his mouth. And when we use oral appliance, we found also the EBO. So for this patient, oral appliance may not be a solution because they may spit them out the oral appliance. My hypothesis is that if we make the mandible protrusion, the exposure of the soft palate may be more. So it may be more easier for her to close to have the EVO. So for her, we also recommend the surgery, and we focus on expand the viropharyngeal airway. This is the immediately post-op. When she open mouth, it would be snore, but she now can close the mouth. When she closes the mouth, there will be nasal exhalation and there will be no snoring. So for this kind of patient, I will usually ask them to use mouth pad after the surgery. So after the surgery, the HI dropped dramatically from 27 to 1.8, and I asked her to use a mouth tape so she won't annoy others sleep, and she felt refreshed and won't feel mouth dry in the morning. So so EVO can happen to patients with OSA or not OSA. And there is another case. This is the last case. This is a 30-year-old male driver. He had also very mild OSA. He had nasal obstruction, dry mouth when awake, and because of the dry mouth, he had easy oral ulcers, and their sleep apnea noted by his wife. And because he is obesity, he used to use gastric balloon and the gastric band to lose weight from 140 to 90 kilo, but it rebound to 125 kilo, so he is still obesity now. And this is his sleep diagram, and you can see that when you supine, there is more desaturation. This is a very unique pattern for hypocrisy. You can see there is spike here and spike here. So he can snore even with nasal twist. He can snore with inhalation and exhalation. So in the DISE, we also found EVO. So for this patient, I also recommend the surgery. We see the diagram again, that if we found the this kind of specific snore pattern, maybe this patient has EVO. So after the surgery, his HI from 7.6 to 4.6 is not very prominent because he's only mild OSA, but his snore dramatically changed from a lot. And he had better sleep with mouth taping. He had less dry mouth and oral ulcers. For this patient, I also do the nasal surgery because he has nasal obstruction. And last but not least, I asked him to use the tirzepatide and the ribelsus to lose weight. When people have better sleep, and they are easier to lose weight. So we ENT surgeons also have roles for patients' weight control. And this is my mentor over Chicago. He mentioned yesterday that tirzepatide is a prominent and very useful tool for us to help patients to lose weight and to have better OSA outcome.